Well, it's so wonderful to be here to see friends and colleagues and individuals that I've cared for, and I'm also meeting new families. If I haven't met you yet, I'd love to, so track me down and just love to meet you and hear a little bit about your story and your journey. I'm also here with Dr. Rana Haloon, who's an advanced training fellow working with me in endocrinology and bone diseases at the Children's Hospital of Eastern Ontario, and Dr. Haloon is funded by Defeat Duchenne Canada along with Parent Project Muscular Dystrophy, and she's looking at aspects of Duchenne care, including weight management, which is really important, as well as bone health and other aspects like transition to adult care from pediatric care. So just really great to be here. Thank you. I'm so delighted that Defeat Duchenne Canada has chosen adrenal insufficiency as a topic to focus on because it is so very, very important. And if there's anything that you hear me say that you want to understand in more depth, please do reach out to me by email or directly here at the conference. So I'm going to start by saying that adrenal insufficiency management has been archived, documented in a very important document called the P.J. Nickoloff Protocol. And the Nickoloff family has been a strong supporter of adrenal insufficiency awareness and management. This is a protocol that was first published in the peer-reviewed medical literature in 2017, and then it was updated, it was revised to ensure that it was maintaining its contemporary knowledge base in April of 2025, and it's going for peer review as well in the next few months. The P.J. Nickoloff steroid protocol was updated by what's called the Optimized DMD Consortium. Optimized DMD is an international working group of neuromuscular experts and endocrinologists and patient representatives that was started in 2023. And the goal of Optimized DMD is to ensure that individuals with Duchenne maximally benefit from their Duchenne-targeted therapy by minimizing the endocrine and bone health complications that can arise from the condition and from glucocorticoid therapy. So very appreciative of the Nickoloff family in supporting this protocol and helping us get the messages about adrenal insufficiency out to families. And you can find that protocol on the Defeat Duchenne website. So what is adrenal suppression? This is something that happens potentially to anyone who's in receipt of steroids. This is not unique to Duchenne. When an individual is not on steroids that can suppress the adrenals appear like this cute little hat sitting on top of the kidneys, and they make a very important hormone called cortisol. Anyone who's receiving steroids, and in this context, whether it's prednisone or deflazacort or vamorolone, that adorable little gland sitting on top of the kidneys goes to sleep. It's not destroyed per se. It can come back if the glucocorticoid dose is changed or the patient comes off steroids. It is asleep. And this is what we're talking about today, is the sleepiness of the adrenal glands on steroid therapy. So to unpackage this just a little bit more, important to understand that the adrenal gland at the bottom makes cortisol. And cortisol is like the gas in your tank. We cannot live without cortisol. And cortisol levels in our body go up in the face of physical stress, like vomiting illnesses or car accidents, and I'll talk about that more in a minute. But how does the adrenal gland know to produce cortisol? Well, it starts with a signal from the brain, the hypothalamus, which is a part of the brain, that makes a hormone called CRF or CRH, and then CRH sends a signal to the pituitary gland in the brain to produce ACTH, which is another hormone, and then ACTH goes to the adrenal gland and tells it to make cortisol. So this is called the hypothalamic pituitary adrenal axis. Many hormones are produced via these kinds of signaling pathways that start in the brain. As I said, cortisol is like the gas in our tank, and when we have physical stresses, it goes up naturally to help us manage those stresses. So fever, our cortisol level goes up. A vomiting illness, our cortisol level goes up. Accidents, whether they're car accidents or even a trip and fall and a fracture, the cortisol level goes up to help manage that, and at the time of surgery, the cortisol levels go up. So when the adrenal glands go to sleep, then we have to give extra steroid to mimic what the adrenal glands would normally do to help the individual get through these kinds of physical stresses. So what's going on mechanistically is that in the face of deflazacort, prednisone, and vamorolone, then those critical signals are not getting to the adrenal gland to produce cortisol. So these steroids block the hypothalamus, and that in turn prevents the anterior pituitary from producing the hormone that turns on the production of cortisol. So there's an interference with this signaling pathway. So what that means is a patient on steroids, if they have a medical or physical stress, as we call it, we have to give them more steroid to mimic the body's natural response to the physical stress. Without stress steroid dosing, patients can have a number of symptoms. And the tricky thing about these symptoms is that they're all vague. They're not, I'm just joking here, but it's not like suddenly the patient develops green little polka dots and you can say, oh, this individual is having adrenal insufficiency. These symptoms are all very vague, and they include fatigue, but fatigue can already be part of Duchenne. They can include nausea and vomiting. What child hasn't had a little gastro? They can include headache. What child has not come home at the end of the day with a bit of a headache because they had a hard day at school, or maybe they need their eyes checked. They can have body aches and pains. We know that that can also occur as a result of Duchenne. And critically, without adequate steroid in the body, the blood pressure drops, and that's why we need cortisol to sustain life. Many times in clinic, I've had patients come to me where I've been concerned about adrenal insufficiency, and the story has been, my child is more tired than usual. My child is having tummy upset, and we don't really know why. My child is having headaches. And often it gets attributed to something else, and the diagnosis is missed. As endocrinologists, we're trained to identify these subtle signs of adrenal insufficiency. And this is such an incredibly important part of the care plan. So how do we deal with this situation? When do we give steroid stress dosing? So we think of it differently whether the child has a vomiting illness or a non-vomiting illness. If the individual has a non-vomiting illness, like fever, a cold where the flu-like symptoms are enough to keep the child at home, not just a little sniffle, but the child is otherwise completely well. And this applies to adults as well. I keep saying child because I'm a pediatrician, but this applies across all ages. If the individual is having surgery, including dental surgery, if there's an arm or leg fracture, which is stressful for the body, then we do recommend giving extra steroid, ideally in the form of hydrocortisone and sometimes in the form of prednisone. We do not use vamorolone to stress dose, and even deflazacort is not advised for stress dosing. And then what about in a vomiting illness setting? So this is a little bit nuanced, and how we are managing this over time is changing. But it goes like this. First of all, remember, if your child is vomiting, or as an adult if you're vomiting, we have a very low threshold for doing intramuscular hydrocortisone. So what do I mean by that? So sometimes an individual will just have one vomit, but they're completely well otherwise. And you might say, do they really need it? They may not really need it, but if there's a hair out of place otherwise, if there is vomiting, but at the same time there's a fever, or they have nausea that's significant, or they're feeling lethargic, then we want to go in and give intramuscular hydrocortisone. And if you're not sure what to do, give the intramuscular hydrocortisone. So we always err on the side of caution. And certainly if there's more than one vomiting episode in a 24-hour period, then that is a situation where we would recommend steroid stress dosing. So a low threshold to intervene and then to call and get assistance. How do we do steroid stress dosing? So the ideal agent is hydrocortisone, which is something that is made medicinally and best mimics the composition of our own natural endogenous cortisol. It also has something called mineralocorticoid activity, which is the way in which we maintain our sodium levels in the face of a physical stress. And we need healthy sodium levels to help us maintain our blood pressure. So as endocrinologists, we prefer hydrocortisone as the steroid stress dose agent. Prednisone is sometimes used in some clinics, and it also has mineralocorticoid activity. It's longer acting than hydrocortisone, and so some individuals on prednisone will be advised to take extra prednisone in order to receive their steroid stress dosing. The problem with that, as I see it, and as you have taught me, is that if you're using your prednisone to do your steroid stress dosing, you might run out of your prednisone early. And then you're scrambling because your prescription has run out early. And so we really prefer hydrocortisone, but prednisone would not be wrong if you have that in place, that you can renew your prescription ahead of time. The other thing we like about hydrocortisone is because it doesn't last quite as long as prednisone, we can sort of more finely tune the dosing in the patient, but either are considered acceptable in current times. And then deflazacort, there really isn't a lot in the literature on deflazacort for steroid stress dosing, and it has less of that mineralocorticoid activity that's so important to help maintain the blood pressure. So we're actually really recommending not to use deflazacort for steroid stress dosing. And then we cannot steroid stress dose with vamorolone. Vamorolone is different because it is antagonistic to the mineralocorticoid receptor. It actually blocks that pathway that helps keep the blood pressure up in times of physical stress. As well, just the safety and efficacy of using vamorolone for steroid stress dosing has not been studied. But because it blocks that important pathway to maintain blood pressure, we certainly know that we cannot use vamorolone for steroid stress dosing. A couple of the nuances with respect to vamorolone. There's been some questions about transitioning from classic steroids to vamorolone. What we know is that vamorolone 6 milligram per kilo per day is the dose that has shown similarity to prednisone and even deflazacort in terms of the muscle effect. Based on our current understanding and based on what we see in the clinic, it does look like it's safe to go from classic steroids to vamorolone 6 milligram per kilo per day from an adrenal perspective. So you should not go to a lower dose than 6 milligram per kilo vamorolone per day if you're transitioning from classic steroids to vamorolone. During that transition, if you were to have those adrenal insufficiency signs, then you would need hydrocortisone in order to make sure that you don't develop adrenal insufficiency. And during any transition from classic steroids to vamorolone, you need somebody monitoring how the child or the individual is doing. If transitioning to a lower vamorolone dose than 6 milligram per kilo per day, we recommend that you get a hydrocortisone prescription in order to handle that transition, because we cannot guarantee during that transition that you would not develop adrenal insufficiency signs. So anything under 6 milligram per kilo per day, you should have a hydrocortisone prescription to get through that transition. If you're on 6 milligram per kilo per day during the transition, we think you are likely to be okay from an adrenal perspective, but we still want somebody monitoring the signs, and we want you to have a hydrocortisone prescription in case there's any sort of a problem. And then here's what we know and what we don't know about vamorolone. I think it's really important when there's a new drug that comes to market that families and individuals receiving the medication are very clear about what we know, what is the evidence that led to the approval by Health Canada, what does the drug not do, and what are the things that we have yet to learn through research. So we know that vamorolone has similar muscle efficacy. That means that in clinical trials, the muscles and the strength did as well as prednisone and deflazacort up to 3 years of exposure. We know that vamorolone normalizes linear growth. The growth is normal. The genes that are responsible for normal growth are functioning well on vamorolone, whereas they're suppressed on deflazacort and prednisone. We know that vamorolone improves the metabolic activity, the extent to which the bone is alive and repairing itself in terms of the bone biomarkers that we measure. And we know that the fractures of the spine are less frequent on vamorolone compared to classic steroids, but not absent. And so we still have to do bone health monitoring, as I explained earlier. We know that vamorolone does not prevent excess weight gain in all patients. We still see weight gain in many patients. We know that it does not prevent the adrenal suppression, and we know we can't use it for steroid stress dosing. And what we have yet to learn is the impact of vamorolone on muscle strength and scoliosis beyond 3 years of use. We need to better understand the impact on the heart and the lungs over time. We need to better understand the impact on metabolic health, like blood pressure and cholesterol and lipids. We don't know if the long bone fracture frequencies are less on vamorolone, and we don't know if pubertal development is normal or not on vamorolone. And there's a longitudinal study going on in the States called the Summit Study that's seeking to answer these questions, and there's a study in Europe called the Guardian Study that's seeking to answer some of these questions. Very important not to ever stop any steroid abruptly. You can't just stop it. You have to speak to your healthcare provider if you're in a situation where you do want to start to think about weaning the steroids for whatever reason it is that you decide collaboratively with your physician. You have to have a steroid weaning protocol, and that applies to all the steroids. And an endocrinologist is trained to help guide families in how to safely wean steroids, and you would only do that in the face of having a steroid stress dosing approach as well. Very important to have a care plan and a number to call for guidance if you're worried that your child is having signs of adrenal insufficiency. Who has a care plan in the room for your loved one? Okay, I'm not seeing a lot of hands up, so we need to chat. So this is very important, and this is something we're working on with Defeat Duchenne Canada and other advocacy groups, is to help families develop these care plans. They're sort of like an insurance policy. You hope you never need it, but if you do, you're very glad that you have it. We developed just a little mnemonic for families to sort of remember some of these principles: stress, have a sick day plan. Your treatment of the underlying disease continues. You stay on your vamorolone, you stay on your deflazacort, you stay on your prednisone when you have adrenal insufficiency, and your hydrocortisone is supplemental, it's extra. Reactive vomiting, have a plan, know when to go to the emergency department, and when in doubt, go to the emergency department. Know that surgery requires extra steroid. Make sure you tell anybody who wants to do surgery on your child that they need steroid stress dosing. And this is really just an important part of the overall care plan for the reason that you can see there. Now, we had Defeat Duchenne Canada. We collaborated with them to have a little competition to develop a little slogan for everyone. And Rachel Widsky from Ottawa submitted the slogan that won the competition, and it says, "Don't cut it close, take another dose." And what does that mean? It means if you're not sure what to do, take the steroid. You will never have any issues or get into trouble with taking a dose of steroid till you can reach somebody to get more information. So it's not something that we agonize over. Should we do it? Should we not do it? If we think about it, we do it, and then we gather more information to understand about more doses beyond that. So thank you, Rachel. She's given us such a gift with that slogan. And finally, I'll just say that the understanding about endocrine and bone health consequences in this condition is really evolving. As Dr. Campbell and others have said, the knowledge is evolving very quickly. We're evolving with it. And so the Optimized DMD Consortium, one of our remits is to make sure that we're staying abreast of the latest knowledge, that we're contributing to it through research, and that we're bringing the latest knowledge to all of you as the community. And that is our commitment to you, and why I so appreciate coming here and speaking to you about this very important topic. So thank you for all that you've taught me, those of you who have worked with me in any capacity, whether as a family or as another healthcare provider, and I appreciate the opportunity to bring these important messages to you today. Thank you. Do we do questions now or later? After, okay. Dr. McAdam.
So I'm going to continue the discussion that we started with Dr. Ward and talk a little bit more about illness and emergencies. So we've covered right now adrenal suppression, and we've also talked about the resources that are available through Defeat Duchenne Canada, as well as the PJ Nickoloff protocol. I'm going to talk a little bit about rhabdomyolysis, fat embolism syndrome, leg fracture treatment, and I'm going to try and keep it short because I know we are tired. It has been an amazing day, but there's been a lot of information, and I do have a few cases at the end for a little bit of participation before we finish up. On the Defeat Duchenne website, they do have this other mnemonic, and it's called THINK. So in an emergency, you should take your equipment, drugs, and important documents with you to the hospital. And we heard from Dr. Amin earlier about bringing your respiratory equipment with you, bring your drugs. We know deflazacort's not widely available, and when vamorolone is here, it may be harder to get access to, so bring that and bring your emergency stress dosing of your medication, because in the emergency room, it may take them a while to figure out what their next steps are, and if you have that with you, it'll help guide them. Hand your emergency information card to the medical team. Inform the medical team about oxygen precautions with close CO2 monitoring. So in an emergency, you can receive oxygen if you need it. However, particularly if you have any respiratory muscle weakness, the CO2 needs to be monitored, because if you just give oxygen, your CO2 levels will build up and you stop breathing. So this is a critical piece of information that sometimes could be missed in the emergency room, and this is written on the emergency cards as well. Notify your primary care contact. Now, you don't have to do that in the emergency. That's more like after the emergency, but they do want to know if you've been in the emergency room. And keep your important documents with you. Some families have a grab bag, which has all of the information in it. Some families have it scanned on their phone. Really, it doesn't matter how you do, what your strategy is. There are wallet cards that'll have the information that you kind of scatter them around, school bags, in your wallet, whatever works best for you and your family, but it's important to have this information, because in the emergency room, you may be seeing a doctor and a nurse that has never heard of Duchenne muscular dystrophy before. And so you are going to be the expert. You as an individual, if you have Duchenne, are going to be an expert. And and having this emergency information can be very valuable. Okay, switching gears. Rhabdomyolysis. I know we've talked about this a little bit throughout the day today. I'm going to walk you a little bit through it. I know I've also spoken to some families about this today as well. So rhabdomyolysis is a fancy medical word for rapid muscle breakdown. And when your muscles break down fast, they release this protein or this color or this pigment called myoglobin. Myoglobin goes through the blood and is filtered through the kidneys, and then you can actually see it in the pee. It turns the pee a different color. My next slide has a picture of the color. And the key thing is, if this is happening, this is a medical emergency, you have to go to the emergency room, because this clogging of the kidneys can cause acute kidney injury. So we talked about rapid muscle breakdown. The protein is from the muscle is seen in the urine. The myoglobin can clog the kidneys, and this is not subtle. The pee is brown. So in the morning, your pee could be a little bit darker yellow color. That's okay. It could be clear if you've had a lot of fluids. That's okay. But if you see this brown cola, coffee, tea-colored pee, this is something you have to go to the emergency room for. A very common cause of this is extreme amounts of activity. So we want people moving around, we want people doing exercise, but sometimes with a lot of exercise, then we can see this. I have seen it sometimes after trampoline birthday parties. So you won't hear me say no trampoline birthday parties, but what you'll hear me say is, if you're going on a trampoline, take a break. And so really, and I think Charisse was talking about it earlier, think about other highly preferred activities so that when you're having a break, you aren't causing a lot of distress for the youth, okay, or the child. Now, I hope this never happens to anyone, but if it does, you need to know to go to the emergency room. So go to the Emerge. They are going to check some blood work. They're going to check the urine. The CK is going to be very high. They're going to be monitoring the kidneys, and they're going to be giving IV fluids, because the IV fluids are going to help flush that myoglobin out of the kidneys and help protect the kidneys. Sometimes you'll be there for a couple of hours. Sometimes you're going to be there for a couple of days. But I just really want you to go to the emergency room. And I know we've made a few adaptations to some of our stress dose guidelines, but I do talk about adrenal insufficiency, especially with this significant stress upon the body with rhabdo. And just as you heard it, don't cut it close, give an extra dose. I'd say if you're going to an emergency room, you need to let them know that your child is also on corticosteroids if they are, and we need to be thinking about the adrenal glands. So when you go home, your child may experience some muscle weakness. Their muscles may be sore, and this is when rest is going to be important. Continue your good hydration just to help protect those kidneys, and teach your child to look at their pee. I know. People don't want to talk about it. I want kids looking at their pee all the time, because when they're in school, when they're at friends' houses, when they're at birthday parties, I want them to know what it looks like. I say, take some coffee without milk, or tea without milk, or cola, put it in the toilet and say, if you see this, you call me. Or if you see this, you tell a teacher and they will call me, because we do want to know about this. Okay, now I'm going to move on to fat embolism syndrome. This is a very severe medical issue. It is very rare, but it is important for you to know about. Fat embolism syndrome is something that doctors are very familiar with if they're thinking about the elderly. When they're thinking about children who are younger with Duchenne, this isn't going to be the first thing that they think about. As soon as they think about it, they know what it is, but it isn't going to be something they're going to think about. It is written on those emergency cards to help prompt the doctors to think about it. So, fat embolism syndrome can be seen. It is not seen with every long bone fracture, but it can be seen with long bone fractures or body trauma. In your bones, everybody has some fat. That's normal. However, when you're taking a chronic corticosteroids, there's a little bit more fat in your bone, and when you have osteoporosis or osteopenia, there's a little bit more fat in your bone. And so that's why we can see it more commonly in individuals with Duchenne. The Duchenne isn't causing it, but all the other things that we can see with Duchenne increase that risk. And so the things that we can see with fat embolism syndrome are hypoxemia, so that's a fancy word for lower oxygen saturation, neurologic abnormalities, and that can be anything from I've got a little bit of a headache, or I'm sleepy, or I can't wake my child up. So there's a wide range of those neurologic abnormalities. And the petechial rash, that's part when you're thinking about fat embolism syndrome, but that takes a couple of days to occur. So you are not going to see that acutely. So it's more going to be the lower oxygen sats, some neurologic changes, and then when the doctors are doing blood work, they may also see other changes. So if you've had a fracture, and if there are any breathing difficulties, neurologic signs, when you're going to the ambulance, tell the paramedics about fat embolism syndrome, tell the doctors about fat embolism syndrome so they think about it. The treatment is supportive care, but they have to know they have to think about it before they'll give that extra supportive care. They will get there, but it's better to prompt them early. So that kind of brings us to leg fracture treatment. Now, leg fracture treatment is very nuanced. The right decision for you as an individual is going to vary based on so many different factors. So my next slide is really talking about some of the things to consider if your child or if you as an individual have a fracture of your leg. So we know fractures are more common. In Duchenne, there are weaker bones. We started talking about that both in the panel as well as with the last talk. And we just have to keep in mind fat embolism syndrome. So if your child has a fracture, know that there are surgical and non-surgical treatment options. The orthopedic surgeon is going to be making that decision. Some factors to consider are ambulatory status, so are you walking or are you using a wheelchair for mobility, the severity of fracture, and the location of the fracture. Some fractures there are no surgical options for, so your treatment plan is going to be a cast. Some fractures you could do surgery or you could have a cast, and so that's when we need to think about if you are walking for mobility and there is that potential, the surgeon is wondering which direction to go, the question is, what option is going to allow for early weight bearing? Because you want to get up and weight bearing as soon as it's safe for that bone. And the orthopedic surgeon is going to help guide that. But they need to know that if it's a possibility, we want to choose an option where weight bearing as early as possible is safe. Also have a conversation about casting in a neutral position. We've heard a little bit about contractures and flexibility. Sometimes this isn't possible based on the type of fracture. The arm or the leg has to be casted in a very specific position, and you want that for the best bone healing. But it's good to put it out there so you can have that conversation with the orthopedic surgeon. Is there any way to have this in a more neutral position? So what I mean by that is if the arm has to be like this, then cast the arm like this. But if we have an option where it can be a little bit more open, then that's what we want to do. Just because when we're thinking about when that cast comes out off, we want to make sure we have that flexibility. And then the last one is no walkers. And so my concern about walkers is that you have arm muscle weakness. So if you're using a walker, you're putting a lot of strain on those arm muscles. And when you're putting that strain on that arm muscles, similar to drop falls that we can see from leg muscle weakness, we can see drop falls if you're putting a lot of weight through your arms. And our concern is falling on the walker and causing more injury than if you were walking a different way, maybe with someone helping you and holding your arms. So there are different strategies because we want people up and moving as soon as they can be, but maybe be a little bit more hesitant around walkers. Okay, so that was rapid fire. So now we're going to move on to cases. So I have 2 cases, and it's just really going to highlight some of the things we've talked about. It is going to be interactive. We have multiple choices for the different scenarios and different parts of the scenario. So I think probably just raising your hands, and for those that are online, you can think about or you can talk with whoever's in the room with you what answers you think are the right answers, and then I'll also talk about that as we're going through the cases. So case 1. Samir is an 8-year-old male with Duchenne, treated with deflazacort, and this morning he woke up with a temperature of 38, and he has some body aches. First question, what body temperature is considered a fever? So we have A, which is 36 degrees, B, that's 37.5 degrees Celsius, and C, that is 38. So now is the interaction. Okay, is it A, 36? Okay. Is it B, 37.5? Okay, I've seen a couple of hands. Or is it C, 38? Okay, I'm seeing more hands. So you're right. 38 degrees is what as doctors we consider a body temperature. But going back to that stress dosing, if you're feeling really fatigued, does it matter you have a temperature? We know you're unwell and you're feeling really fatigued, so that triggers what Dr. Ward was talking about. Okay, so what should you do with his steroid medication? So lots of options here. I couldn't collapse them down. So do you just not give his morning dose of steroid? Do you give his morning dose of steroid? Do you give a stress dose of intramuscular hydrocortisone? Do you give an oral stress dose of hydrocortisone? Or do you give, or it could be hydrocortisone or prednisone, or do you do B and C, which is morning dose and intramuscular, or is it F, which is morning dose and oral hydrocortisone? All right, so now we're going to go through it. Is it A, do you just not give anything? I'm very happy, no hands. Okay. Is it B, give his morning dose of steroids? Yeah, I agree. You should give his morning dose. Is it C, give a stress dose of intramuscular hydrocortisone? All right. Is it D, give an oral stress dose of hydrocortisone? All right. Is it E, give morning and give an IM dose? So I'm seeing some hands there. Or is it give his morning dose and the oral stress dose? And so I'm seeing more hands there. I think it really comes down to you want to give extra steroids. For this case, because we have a fever and we're feeling tired, I'd be very comfortable giving the morning dose and an oral dose of hydrocortisone, because we haven't gotten to that part where we're vomiting and we can't keep things down. But stay tuned. All right, so this is what Dr. Ward was talking about: non-vomiting illness, fever, flu-like symptoms, give extra steroid. All right, can you give a medication to help with fever? A, yes, B, no. So how about A? I saw a few hands. Absolutely, help them. They're feeling crummy. You can give medication to help with fever. In general, I recommend Tylenol or acetaminophen, and the reason for that is sometimes when you're older and you're on other cardiac medications, some of those cardiac medications work through the kidneys, and Advil works through the kidneys, or ibuprofen works through the kidneys. So in general, I recommend acetaminophen. But yes, treat the fever. All right, the next day, Samir's not feeling well. This morning, 10 minutes after Samir took his regular steroid medication, he vomited. He's not able to keep anything down. So now we're switching treatment algorithms. All right, so what do? Do you wait till tomorrow to give the next steroid dose? That's A. B, do you immediately repeat that dose of steroid, of his regular typical steroid? C, do you give him the oral steroid stress dosing? So that's either hydrocortisone or prednisone. Or D, do you give an intramuscular dose of hydrocortisone? All right, I'm seeing some nods. All right, is it A, wait and do nothing? All right, B, repeat it? He's keeping nothing down. It's probably going to come right back up. C, give some oral stress dosing? No, because it's going to come right back up. D, give an intramuscular dose. Excellent. Universal hands. Dr. Ward is so happy.
I'm still learning at 5:30.
Yeah, I know. It's kind of incredible. I know, because this was supposed to be changed. I know. I guess, I don't know, maybe it wasn't on the, I know. That's okay. I did remove the not. Yeah. What do you do? I feel like a teenager, not. But it is, what do you do? So we want you to give the intramuscular dose of steroid. And if you aren't keeping anything down, you got to go to the Emerge, because we worry about dehydration. And that, I'll let Dr. Ward speak more to this, but that intramuscular dose of steroid is giving your body that extra amount of steroid that it needs, and it's buying you time, because when we're looking, if you need longer term IV steroids because you can't keep things down, the dosing is every 6 hours, so it's giving you some time. And the other thing I have to say is, if you're going on a trip, if you live up north and you are far from a hospital, it is very important that you have this IM dosing at home with you or with you, so that if an emergency happens, you're able to give the medication while you're trying to get to a hospital. Do you agree with me, Dr. Ward? 100%. Okay, perfect. I know, what do you give not? I don't know. I think that speaks to it being a long day. All right, so after you give the intramuscular dose of hydrocortisone, what do? Do you monitor him at home? Do you call the endocrinologist or neuromuscular team? Do you go to the nearest emergency department? Or are you doing a combination of calling people and going to the emerge? All right, I'm seeing some hands. I agree. Okay, case 2. We are really close to the end. So John is a 50. Oh, sorry. The answer was go to the closest emergency room, but also let your care team know. And it depends on the time of day. You may not be able to get in touch with someone. Some teams have on-call physicians that you can get in touch with. But if you can't keep things down, you have to go to the emerge anyways, because we want to make sure from a hydration standpoint, and if you need another stress dose of steroids, they're going to be able to help make that decision in the emergency room. All right, case 2. So John is a 15-year-old male with Duchenne. He uses a wheelchair for mobility. During a transfer, he had a fall to the ground. He immediately experienced leg pain. His parent was able to transfer him to the couch. He developed a headache, and about 15 minutes later, and had some difficulty breathing. So, what would you do next? Would you wait to see if he feels better over the next 30 minutes? So that's A. So I hear a no. Excellent. B, call 911. Yes, this is a medical emergency. Give an intramuscular hydrocortisone injection. Yes. Give oral stress dose steroids. No, because we're going right to the IM dosing. So breathing difficulties or neurologic signs after a fall is a medical emergency. All right, so that is it for the cases. You guys are absolutely incredible. I can't believe, I think we started around 8 o'clock this morning. And so I'm gonna bring Dr. Ward up because I'm sure you have many questions for Dr. Ward. And we really are at the end. It's almost a home run, I'd say.
I'm so glad we did those cases. They're so illustrative, aren't they, when we really break it down to what might happen in real life. So that was great. Laura, a couple questions over here.
You mentioned the being remote or on vacation. I know as patients of Dr. Ward's, we carry 2 IM on board at all times, so that if we can't get to the ER, so what I'm saying to everybody is, just don't settle for 1 vial in your your emergency stress dose kit. Ask for that second.
I always think being prepared is a good idea, and so I think that's excellent.
And may I just add that sometimes the individual is living at different places at different times or sleeping over at grandparents. So you do want to think about the locations where a child will be sleeping or living, and making sure that everybody who's in charge on a given day has what they need.
Hi. I have a few questions about the stress dosing. So just to give you some background, my son is 20 years old now. In the past, we were always told stress dosing we should be given deflazacort extra. So it sounds like there's been a change in the landscape. And so I'm just wondering where I could get that information and how I could get it dosed for my son and what the dose would be. And
Yeah, so that's interesting. So the knowledge has changed, and that's why I said at the end, you know, we're all constantly learning from one another. And where the notion of giving deflazacort came from was when we really started to push steroid stress dosing, which really needs to start in the hands of the neuromuscular physicians because they're the prescribers. This education has to happen immediately. A lot of neuromuscular experts understandably said, oh my goodness, we're not used to prescribing hydrocortisone. This is a lot. Can we just use the steroid the individual is already on? And there was also emerging precedent for that in the rheumatic conditions and other disease areas where steroids were being used. And so that was adopted, and we thought that that was better than nothing. And then when vamorolone came along, we really started to dig deep into the mineralocorticoid aspect of the access and the protection. And we realized that that mineralocorticoid receptor was really important in how individuals were handling physical stress. And so then we went back and we really finally tuned our knowledge around deflazacort and prednisone. And that's where we got thinking, you know what? Deflazacort doesn't have as much mineralocorticoid activity as we would like. So what are we going to do? We're always going to make recommendations that are the most conservative because adrenal insufficiency is so serious potentially. And so when we decided to go out with our messaging as an optimized DMD consortium, we wanted to be very clear. And we said hydrocortisone and prednisone are okay. They have sufficient mineralocorticoid activity. Deflazacort and vamorolone do not. And so we landed very squarely. And that was us discussing and reading and looking at the literature and learning from our patients in terms of their experiences on these different drugs. Does that make sense?
Yeah, I'm just wondering, can you comment on the dose that we should be, and where we could get a prescription? Because if I just go to my family doctor and say, hi, I need a stress dosing of hydrocortisone, they're going to have no clue what to, provide me.
So when you look at the new PJ Nickoloff protocol, within it, they actually have a beautiful table that talks about weight-based dosing, as well as the body surface area calculation that you can use for hydrocortisone. And so that one table will actually be an excellent resource for your physician to look at regarding dosing. And I'd say in our clinic, we just started changing about 6 months ago, but you bring up a really important point that we have to get the message out to adults that have Duchenne who may not be followed in different clinics. And I really look to Defeat Duchenne of how can we get that important message out there, because for the people that do have stress dosing plans, they're probably from their pediatric care providers. And so things are changing. I don't, do you have?
Yeah, I would just echo that. And so we can appreciate that, a family doctor or other primary or community care physician might be a little nervous about that, right? And so if they want to get in touch with us, you're welcome to get them in touch with Nicola or myself directly. I'm reachable, through my email. Happy to advise on that. But we really do want to be partnering with everyone who's involved in the care of the individual so that it's on everybody's radar. We're really proud of the neuromuscular experts. There are really many of them taking this on as well, and endocrinologists are now, at least at CHEO, we've moved into almost like a backup role. So the neuromuscular team is doing that upfront prescription. Here's your steroid, and here's your steroid stress plan, and then they come to see me, and I take advantage of the visit for bone health and endocrine otherwise, and just make sure there's a medical alert bracelet, there's a care plan, how's that going, what are the questions. So we're really partnering with the neuromuscular team, and would be happy to partner with any family physician or community partner as well.
Thank you very much.
My question's sort of similar actually to the last one, but for neuromuscular clinics who are not choosing to follow this yet or prescribe the intermuscular dose, we're still new to the diagnosis. So if my son wasn't able to, right now we're told to use deflazacort to stress dose. If he wasn't able to hold it down, vomiting, so our option right now, if I'm understanding, would just be go to Emerge, and they would need to provide the medication. And then my second part of that question is just, we're going on vacation in a few months, so I'm a little concerned after hearing all this of what to do. Is that something we'll be able to find if we need?
Yeah.
Because right now our doctor isn't offering that.
Understand. So this is a really important narrative, and I'm so glad you brought it up. So my first question is, how far do you live to your nearest emergency room? How far from there?
7 minutes.
7 minutes. Okay. So I think it's okay if you were to go to the nearest Emerge when you're that close. I would still prefer you had something at home. I'll tell you that one of my patients had a vomiting illness when we had trouble in Ottawa moving around the city because of the COVID, campaigners, if you will, in Ottawa, right? The truckers. Yeah, and I couldn't move around the city, and my children had trouble getting home for where they were in the city. So we were really locked down in Ottawa, including ambulances. And so my patient accessed the 24-hour on-call service and had IM hydrocortisone at home, and we were able to safely help that individual who could not get to CHEO for emergency care. So 7 minutes That's great. But now you're going to travel, and you're not going to be 7 minutes necessarily to an emergency room. So we need to help support you get access to IM, hydrocortisone, and oral stress dosing. So let's talk and see what we can do to figure that out. Does that sound good? Yeah.
Excuse me. I had a question about ACTH stimulation test. I mean, when you are weaning off the steroids, do we need to do ACTH stimulation test just to reconfirm that whether the adrenal axis has restored or not? Or is it necessary or it's not?
Yeah, that's a really great question. So in Canada, in most clinics, it is recommended I do it. There are some clinics around the world where clinicians have said, look, if I've done a very careful wean of the steroids over a time period that's appropriate for how long the individual was on steroids, and the individual has tolerated that wean without any signs or symptoms of adrenal insufficiency, and a morning cortisol is okay, I'm going to be happy with that. In our clinic, we take it just one step further, and we do the stimulated test. That's when we give ACTH to the patient and we see how the adrenals respond to really verify that they've woken up, so that I can be reassured that if that individual has a car accident or a major surgery or anything else that puts significant stress on the body, that they're going to be okay. But just in the interest of a balanced discussion, there are some clinicians that take a more practical approach. And so I guess I can't say that there's one right or wrong approach, but certainly many of us take that ultra-conservative approach and want to document that we're happy with the stimulated response and that to say those adrenals have woken up.
And is the adrenal insufficiency related to the dose of the steroids, or any dose of steroids would also result in the adrenal insufficiency?
Yeah, that's a really great question. I'm so glad you asked. So there's some rules of thumb, but there's always nuances. The art of medicine and the science of medicine. So any dose of steroids that exceeds hydrocortisone 8 to 12 milligram per meter squared per day, which is a physiological dose, has the potential to suppress the adrenal glands. And there's a little calculation to do that can allow you to figure that out in terms of prednisone and deflazacort dosing. The little tiny nuance there is that everybody metabolizes steroids differently. If any of you, for any reason, ever went on a steroid, you would metabolize it slightly differently. The moment you start to see changes in growth or the roundness of the face or the redistribution of the fat with more in the tummy area, no matter what dose you're on, even if you're on a low dose, lower than what I just cited as the threshold, it means your body is really metabolizing that steroid in a way that the adrenals could go to sleep. So we look at it practically, and then we have that sort of rule of thumb to guide us as well. But those are very good questions. Are you a healthcare provider to ask such sophisticated questions, or you're just on the internet and teaching yourself?
I'm a parent. My son is Duchenne.
Yeah. Well, thank you for the depth of those questions. Appreciate it.
I do have one question. Does diet affect this? Like the stuff that you eat?
That's a really great question, and my short answer to that is no. That what you eat doesn't interfere with the way in which you're going to respond in terms of stress. The little caveat there is that your weight is going to influence your dosing. So when we dose for an emergency situation, we do take into account the size of the individual. As endocrinologists, we were used to dosing on the basis of height and weight and your overall what's called body surface area. However, that's a really sophisticated way of doing it. It means you need to know the height and the weight. So we've actually, as Dr. McAdam said, developed just weight-based guidance, because most people know how much they weigh, but they might not know the calculation that involves both the height and the weight. So that might be a little more than you had wanted to know about, James, and appreciate the question. That's really good to think about the way in which nutrition can impact some of these hormonal pathways. So thank you, James.
We have one online, if I could ask. It says, for Dr. Ward, almost 2 years of a Vamorolone patient. as parents, we're always trying to be prepared and inform others, like school staff, how to proceed in case of more serious emergency outside of the protocols and handout information. Schools don't have a nurse or health technician on site, and there are protocols that prevent first responders to administrate intramuscular injections in patients. At least that's what I was informed by dispatchers in Quebec. In case of a severe emergency with loss of consciousness, where an injection of hydrocortisone is needed, since first responders cannot administrate an injection, what is the window for it to be administered?
Yeah, that's a really great question. So, you know, it depends on the severity of whatever it is that's gone on to precipitate the need for IM or intravenous hydrocortisone. I mean, you have a little bit of time. You have a little bit of time. Exactly what that window is going to vary on the magnitude of the trigger that led to the problem. Now, as you heard Dr. McAdam say, in her case, the individual had a fall and then within 15 minutes started to have difficulty breathing. That would be a situation where we want to call that ambulance. We want to get the ambulance there immediately, get the individual to the hospital and get a dose of hydrocortisone. So we have a little bit of time. If the individual fractured and was well, wasn't having difficulty breathing, then you would have, you know, more time. I'm a little reluctant to put a timeline on it because I think it's nuanced. I would just say to act on it as quickly as possible, but it's not like it's immediate unless it was something like a car accident and there was bleeding and that sort of thing.
Just one little question. Any advice or observations about traveling with the medication and needles, like outside of Canada or across provinces?
I haven't, so for the families that I follow, they haven't had any troubles, especially going through airport security. However, we also provide a travel letter for them indicating that they have needles and they have medication that has to be in their handbag and that they have vials with them. I think the majority of time people are not asked about it, and so it's just an extra security blanket so that we feel comfortable, so that it isn't causing delays. But I haven't had anyone that has had challenges going across.
Yeah, exactly. I haven't had issues either. We provide the letter, and then the individual should be wearing a medical alert bracelet, so don't forget about that, that says steroid dependent. And so that's another sort of layer that if ever it was discussed, you could say, look, I've got the bracelet, it says steroid dependent. This is the steroid that would be needed. That goes along with the reason for the bracelet, and that with a letter, and that should be unassailable. You might also want to include in the letter someone to contact if there were problems at the border, you know, somebody in the hospital or your care provider. So those are some other safety checks. But like Dr. McAdam, we haven't had any families run into any difficulty with travel.
I just had a follow-up question on the one question that was before when it came to the school and the emergency in school. I've been thinking about this a lot. And where we live, we are very near to the hospital, even the school is. But how do I know if there is an emergency call that they are going to take my son to that hospital and not just decide to go and take him to Calgary, which is 50 minutes from where we are. And if they do decide to take him that 50-minute drive, and if it's very emergent, my son does wear a medical bracelet on his neck. The school is aware of his steroid dependency and adrenal insufficiency. All of that information is there. But is he gonna get that stress dose on that ambulance, or is he not? Because the school did not want us to provide the stress dose. They just completely put their hands up, which I don't know why. But I am just wondering what would happen in that scenario. That then suddenly the first aiders decided to take my son into Calgary, and there's no stress dose from us. So is there a stress dose somewhere on the way?
I mean, this is difficult because it's true that in some jurisdictions, the paramedics are not allowed to give steroid stress dosing, and so individuals can get a little bit stuck. I would hope that for paramedics who are not allowed to give steroid stress dosing, that they would recognize with the medical alert and the context the need to get them to a center quickly so that that could be given, and that that would be part of their triage, that they would go to the nearest emergency room because they would recognize that it was something that needed to, happen quickly. So these are things I can't really answer because I don't know exactly how it works in your jurisdiction. But that's another reason why it is nice to have someone close by who can just pop that dose in, and then everyone can breathe easily, because then the next dose would be given a few hours later typically. So there's some uncertainty about this. I appreciate that.
Yeah.
Laura, do you want to add anything to that?
Yeah. I guess the other thing is, you can also contact, I haven't heard this with paramedics, but you can contact your local fire department, and fire departments have different protocols, and you can let them know that your child has this condition and needs this emergency medication, because sometimes it's actually the fire department that gets on scene first prior to an ambulance. And then if they're already in the system, then that's going to trigger a whole series of information that's going to be transferred. So that could be an extra security net when you're thinking about those emergency situations.
You are talking about giving stress dose, and deflazacort or the vamorolone, they don't inhibit the MR, the mineralocorticoid receptors. But in case if someone is on eplerenone or spironolactone, which is already an MR antagonist, then in that case, how would we deal with the stress dose?
Another really great question. So the question is being asked is around this mineralocorticoid receptor, and I'll just clarify something. Vamorolone blocks the mineralocorticoid receptor. Deflazacort does not. But deflazacort doesn't have a lot of mineralocorticoid activity in it. And so for that reason, we don't recommend stress dosing with either deflazacort or vamorolone. And you're absolutely right. If someone is on spironolactone at the same time as they're on vamorolone or deflazacort, which doesn't have a lot of mineralocorticoid activity, then they're at even more risk of having hyponatremia or low sodium and challenges with blood pressure. So this is something that's important to understand, and that's why we recommend stress dosing with hydrocortisone, which has mineralocorticoid activity. We still have some questions about stress dosing on vamorolone and whether the hydrocortisone can completely override the mineralocorticoid block with vamorolone, and this is something that we're learning about as we go forward. Does that make sense? Thank you.
One more question, then we're going to wrap up. Yeah, just since what you just said, I don't know, maybe I understood it wrong, but so if, let's say I see that my son, who is on vamorolone on daily, is having some kind of fever or stuff, should I just step away from giving him that regular vamorolone in the morning and just go straight to hydrocortisone to avoid this, what you have just talked about?
So I just want to say I'm really impressed with the thinking in the room. What you've hit your head on the nail on is exactly what we're not sure. We're not sure if in all cases whether hydrocortisone will be sufficient to override the mineralocorticoid antagonism of vamorolone. Right now, the recommendation is that you should continue your vamorolone and use hydrocortisone as supplemental stress dosing strategy. But we're looking at this very, very closely. We're keeping our eye and ear to the ground, and this is something that may change over time. What I would say is if you're on vamorolone, you need steroid stress dosing, for whatever reason, as we've talked about today, you give that steroid stress dosing, and the individual doesn't perk up and lose the lethargy and feel better and stop vomiting, then you need to go to the emergency room. And that's why we do advise that you have access to some sort of a 24-hour on-call system to help guide you through those kinds of decisions. You know, give the IM hydrocortisone and then call or go to the emergency room, that's for sure. And even with the oral hydrocortisone, give a dose, and if things aren't perking up, call or go straight to the emergency room, and when in doubt, go to the emergency room. So whatever you do, and what I want you to take away from this session the most is when you're not sure what to do, then you get help. Yep. Thank you. Thanks for the really, really great questions today. I'm very impressed with your knowledge and your logic around what you've heard and the way you've been thinking about what you've heard. It's really wonderful. Thank you.